I'm Denise Giambalvo, Director of Member Engagement at the Washington Health Alliance, Member Engagement and Business Strategy. And we're here today to talk about biomarkers and what the role that they play in personalized medicine. So let's go ahead to the next slide. Get this party going. So everyone is muted, but we do have Q&A and chat's enabled too. We ask that you enter questions through Q&A, but if there's any kind of conversation that you'd also like to, stimulate as the program goes, you're welcome to do that through the chat. This is being recorded, so recording will go out to everyone, along with the slide deck that we're presenting. So you don't have to take notes. You'll have this for reference. Next. So as I said, I'm Denise Giambalvo. I'm your hostess and moderator today. And we have Rebecca Hulinsky with us, ready to do a wonderful presentation on genetics and biomarkers. We'll have time for Q&A. Again, please use the Q&A feature in Zoom to enter those questions, and you can enter those throughout the program. We'll just hold till the end to ask them, and then we'll wrap up at 12:30. Next. If you're a member of the Washington Health Alliance, then I'm hoping you're familiar with what you're seeing, and that there's many ways that we bring value. And if you're not a member, then I'm really happy that you're here today to experience one of the many things we do, which is convening people and bringing education to you. But we also have public reporting. We drive market change by assessing what's happening in the market and bringing recommended actions for the many stakeholders that participate in the Alliance. So we have over 150 organizations, purchasers, health plans, providers, pharma manufacturers, anyone that's involved in the healthcare landscape is a member at the Alliance, and many actively participate in committees and others. On the left side of your screen, we have bubbles where we show where we group our different stakeholders. Purchasers are the largest, and that's because we address what's happening in the market from the purchaser perspective. So employers, union trusts, what's important to them. So looking at our data and using that to inform action that'll improve quality, affordability, access, all from an equity standpoint for our workforce. But we also have folks who provide Medicaid coverage. So we don't forget about those people either. It all carries over, and we really feel that when we address the market for the workforce, that those changes carry over to the other side, and vice versa. When CMS puts things in place, it helps to inform us on changes that need to happen in the commercial market. Next. So how can you become involved? Again, being here today, that's one way to be involved with us. We have a forum coming up on June 6th. If you're not registered for it, I recommend doing that. There's a link in the chat. You can click through right now and register yourselves. Members attend for free. Very small fee for those who are not members to attend. This is an in-person event. We do have a virtual option. More and more people are joining us in person, and it certainly makes for a more dynamic event when you're in the room with us. But during that healthcare spend more, get better, we'll be talking about our recently released hospital price transparency report. We have fabulous reactor panel put together to have a deep discussion on that. We'll be talking more about cell and gene therapy during that event, and also primary care and the role primary care plays in the answering this question of, if we spend more, do we get better? We have a group that is focused on equity that resulted from us last year releasing our reports using the area deprivation index. So we now stratify our quality and total cost of care across 10 deciles, the most advantaged neighborhoods to the least advantaged neighborhoods, and look at does advantage versus disadvantage impact the quality of care you receive and the total cost of care. And the answer is it depends on what measures, but there's definitely where you live matters. Absolutely. Hospital price transparency, as I mentioned, we just released that report on May 7th, and so much more to come on June 6th about that, and what's happening in Washington State. And then our ongoing work of focusing on quality and health economics. We have 2 separate committees for that, who also meet a couple of times a year. They co-join those committees to be able to share ideas and learn from one another. And our purchaser affinity group is just that, it's purchaser only. So employers, union trusts, it's an opportunity for you to come into, I'm going to call it a safe space where you can share information, ideas, experiences with your peers and learn from one another without having any outside influence from vendor partners, provider partners. Next. So we have a poll for you. We'd like to get some a little bit of an idea of how much you know about genetics. So we're going to go to Slido, and our question is, what comes to mind when you hear the phrase genetic testing? So we'd like you to put those words in. There's a link in the chat that you can click through, and I think I should be seeing a QR code also, but I'm not at the moment.
My Zoom connection quit, so give me just a moment and I will get it back.
All right, thank you. But if you're on, your computer, well, even if you're on your phone, you should still be able to click into that link and get to the Slido screen. And there we go. So people have already started putting things in. So let's see, expensive as number 1. Look at that. Got some people giving us scientific genomes sequencing like that. Targeted therapies, yep. It's very specific. That's that personalization. Loss of ABI. You know what? I'm not sure what ABI stands for. Becca, you'll have to help me with that one. Genetic risk factors, diagnosis, love it. But expenses still becomes the number 1 thing that comes to people's mind, right? And just wait till you get to the therapy part.
Mm-hmm.
I want to talk about expensive. This is fabulous. Thank you. Really, I like seeing this participation. So, so this helps us. This helps to frame things up for what's next in this discussion. So I'm very happy to introduce Rebecca Hulinsky. We can go, yeah, thank you. Oops, wrong screen. So Rebecca's a certified genetic counselor. She is with Quest Diagnostics, and they have sponsored this event today, and we really appreciate Quest working with us to narrow on this topic. It's not coincidence that we changed this, that we've chosen this topic, because we are going to continue discussions along these lines. And as I said, on June 6th, we will have a panel just about cell and gene therapy. So this is a nice lead into that. In her role, she provides support and strategy at Quest. She works with the health plan partners in genetic test review and adjudication. She's very passionate about this topic and working with stakeholders, multi-stakeholders. And her past experiences with Humana as first a genetic counselor, and then on the provider payment integrity team. She's developed genetic testing work streams with various departments, including national laboratory contracting, medical coverage policy, clinical operations, utilization management. I mean, she really lives this. There we go. You got it, Teresa. Just next slide. Oops. Yeah, she shared with us in the prep meetings how she was, I think, like 17 working in a lab, and how manual all of this was at that time versus where we are today. So really happy to bring Rebecca to all of you with her wealth of knowledge and expansive background on this topic. And so we could just get those slides up.
I'm getting you there.
Rebecca, I kick this over to you.
Am I going to have to use the emergency number, Nick?
You're not.
Would it help if I share my screen, Teresa?
I think I'm
Maybe.
there. Let's see.
I can take over. Why don't I just do that?
No, I got you.
Okay. Is that me or you?
It's me.
Okay, next slide.
Okay. Okay, are we ready? Do we got it?
We've got it. We can
Okay, okay. All right. Thank you so much, Denise. And yes, as Denise said, this is my passion. I can't even explain how much this is my passion. I am very excited to be here today and to talk with you all. I really like how expensive came up as the #1 word when we think about genetics. And I'm going to challenge that a little bit, because I do think genetics is expensive, but I do think we're at a point where we need to also think about what's the value, because things can be expensive, but is it giving us value? Because I think that's the other part about genetic testing is, what are we getting from it? So part of this that we really want to talk about is understanding, first off, what is genetic testing? And I do think that that is one of the first things that we sort of have to level set about. So what we're going to do today is do a quick Genetics 101, really high level. And then I do want to talk about a few common genetic tests, again, really high level. And then I'm going to do a little bit of a deep dive to talk about some cancer genetic testings to get into that conversation about expensive versus value. And how can genetic testing help us with thinking about the personalized medicine and how it helps us get to being healthier. Next slide, please. Okay, so first up, what is genetics? So go ahead to the next slide. So again, I'm not going to go all the way back. We're just going to go to very basic genetics. So when we talk about genetics, what I want to talk about are the very basic packets of information that make living things living things. They tell our bodies how to be, first off, they tell our bodies how to form, how to make an arm or a leg or a brain. And then they tell us how to grow, how to function, how to release our enzymes, how to digest food, how to fight off infections, even when a cell needs to grow or when a cell needs to die. And these directions are organized into a series of letters in what we call a genome. And so these orders of the letters tell us how to do a lot of different things. Now, you would think this would be very complicated and very different, but the truth of the matter is 99.8% of these letters are all in the same order. And it's that 0.2% that gives us our variation. And so what we're really thinking about when we talk about genetic testing is just that small percent of variation in the population that tells us the different things. So that 0.2% tells us what we look like, why we look different from one another, if we like cilantro, if we don't like cilantro. But in healthcare, it can be important for things like diseases. And then sometimes the variation really is nothing. So when we talk about genetics and genomics, it's a lot of words, but it's really just these packets of information. And I know that's very high level, it's a lot of words, but it's very simple. Packets of information, and it's just the directions on how to be a living being, essentially. So next slide, please. And so this is, again, if any of you are genetics people, you've probably seen this analogy, but I really like to keep it high level. So I really think about genetics. We want to think about it like a set of books or directions. These are our directions. And I know nobody goes to the library anymore and gets books, but just stay with me. There are libraries, there are books, and each organism has their own genome or set of books. And these are the directions. So for whatever organism it is, there are different sets of books, and these are the directions. So in humans, we are organized into these 46 books, and then in the books, there are the chapters, which we call genes, and those are the directions, and they tell us what should we do. So if you open the books, next slide, please, you can read the chapters, and you have to have special equipment to be able to do this. So again, in the olden days, you had to go to the library, you had to know where to find the book, you had to open the book, and you had to read the book. And so in the cases where we would know what the gene was, we would open the book, and we would read the chapter, and we would know what that was supposed to do. So for example, everybody loves the BRCA or the BRCA gene. It's involved in cancer. So when we read the chapter and there are no mistakes, everything is fine. That's what the chapter tells us to do. But if there is a change in that chapter, now our body doesn't know what to do. It just goes all haywire. So for example, if the book is supposed to say the red car was old, but now it says the blue car was old, it may not matter. No, it may not matter to our body if it's a red or a blue car. But sometimes if the change makes it so the story doesn't make sense, our body doesn't know how the story ends. So it can make a difference. And I know that's very simplistic, but that's the basis of how we talk about genetics. And again, in the olden days, like in the 90s, we had to go to the library, we had to find the encyclopedia, we had to open it up, and we had to know what the book was supposed to say. And the things that have changed over time is, all of that is electronic now. It's on the internet. We can look it up. We don't have to go to the library anymore. We know what the story is supposed to say. We know all of these different things, and it's a lot easier to find that information. But the basics are still the same. We need to know the story. We need to know how it ends. We need to know if there are changes in it and what those changes mean, and if we can still understand the story. And like I said, I know that's very basic, but I like to start with that so we know what the next piece is. So the next slide, please. So when we talk about genetic testing, the reason it's important, there are two types of genetic testing that we're going to talk about. And the basics of it is, what's your question? What type of testing are you doing, and why is it important in healthcare? So the first type of genetic testing is kind of the type of genetic testing that we usually think about. When you learned about genetic testing in high school or junior high, or whenever you learned about it, college, this is the type of genetic testing that you sort of think about. It's called germline testing. And this testing is the type of testing that you were born with. So this is the testing that you inherit from your mom and your dad. So these types of testing are done on your blood because in theory, all of your cells are the same because they came from that egg and the sperm that came together, and they're copies of copies of copies. And there's kind of three reasons you want to do this. You want to know, number one, carrier screening. So the answer to, will my children have a condition? So a parent doesn't have these conditions, but they are conditions where if you pass these genes on to your children, and so does your spouse, then your children can have them. So these are conditions where oftentimes these tests are offered to parents when they are pregnant or thinking about getting pregnant. So that's one kind of genetic testing that we think about. The second type of testing that we think about is risk assessment. So that means, will I get? So it's no longer about will my children get, but will I get? So this is often done when somebody has a family history of a condition. So for example, if somebody has a family history of cancer, or if they have a family history of Alzheimer's disease, or any kind of adult onset condition. So these are genetic tests where somebody is worried that they'll get a condition later in life that other members of their family have. So that's another type of genetic testing that someone may pursue. And then lastly, and again, this is oftentimes the genetic testing where it really sort of started, where it's a diagnosis. This is often done in children with birth defects. So it's really, what do I have? What does my child have? So when a child or a person has multiple anomalies, for example, they want to know if there's a gene or a change in their genes that is kind of causing all of these things. So those are the germline testing that you can kind of think about when somebody says genetic testing. Will my children have, will I get, or what do I have? Three types of genetic testing you can kind of think about. The second type of genetic testing that is probably the fastest type of genetic testing that we're seeing is something called somatic testing. And what somatic testing is these are DNA changes that happen in cells over a lifetime. So we're born, our books are all normal, our chapters are normal, the story makes sense, but over time, our cells make mistakes. And this change is pretty much in cancer. This is what causes cancer. So essentially what happens is our cells are copies of copies of copies. And again, I know we don't have copy machines anymore, but back in the 90s, when we had copy machines, if you made a smudge on a copy and then you made a copy of a copy, that smudge would kind of just keep perpetuating. So it's the same thing. We're looking at types of changes in these cells that can tell us information about those changes and what can we do with them. So same thing, there's kind of three different ways that we can do this genetic testing. One, we're looking for genetic changes that cause cancer. So for example, again, the BRCA gene is one that people are very familiar with. we know that changes in that particular chapter can cause tumors. So we know that when that chapter is messed up, our cells turn into tumors. So we can do cancer genetic testing on those tumors and say, oh, this chapter is messed up, that causes a tumor. It can also tell us what type of cancer it is. So for example, there are certain genes, changes in genes that define what type of cancer you have. And more importantly, the next piece is where we're going in the future is, can we target certain genes to kill the cancer? So for example, if there's a change in a gene, is there a drug that will target those changes in those cancer cells and kill off those cancer cells? So that's probably the most important part of where we're going in these cancer genetic tests. So again, we're talking about what type of genetic tests are available on the market. We have the type that are the ones that you're born with, and the type that are growing really fast are the type that you accumulate over time. So it's important to understand the differences in these because we're talking about what's the usefulness and therefore the value in these tests. Because again, how much does it cost? You can't just say a dollar amount. We need to know what's the value, because if a test costs $1,000, but you can save $10,000 in a pharma treatment, then maybe that has more value. So that's an important part when you're talking about these tests. What can they do? What question are they answering for you? Okay, next slide, please. So now we've talked about sort of the baseline of what are we talking about with genetics? Why are we talking about it? Why is it hot? So let's talk about it. Back in the olden days, like I said, in the 90s, finding variation in genes was very laborious. Like I said, we didn't even know all the genes. We knew we had genes. We didn't even know what they all were, though. So this little thing happened. I don't know if you remember, there was the Human Genome Project. So then all of a sudden we knew what all the genes were. And we started knowing where the differences were. We knew what all the chapters said. We did not necessarily know what they all did, but we knew what they said. And like Denise said, there was little me back in '98, my graduate program. I was sitting there in the lab sequencing a single gene in 10 people. It took me 2 years looking for variations that may cause disease in a single disease called Marfan syndrome. Now, 1998, they didn't pay grad students a whole lot, but you can imagine it wasn't a really good return on investment. And I wasn't getting real far real fast, right? So you can imagine that that wasn't really a very valuable test at the time. But that's what we did. We were looking for variations in genes to try and understand them. And so that's what was happening. Genetic testing was happening in academic research labs done by grad students, looking for these changes causing these rare diseases. And in many cases, you were looking for genes that cause diseases. And so that was back, even in 2023, we're still looking for genes. So things have changed. So then, next slide, please. What happened in between 2008 and 2012-ish? There was this huge growth of bioinformatics. So remember in the iPhone, that was 2027. So our ability to sequence the gene through the Human Genome Project changed. So instead of being able to do single genes using radiation and little grad students, changed that we were able to sequence multiple genes, read multiple books, multiple chapters at the same time on a computer, and be able to process that and store these vast amounts of data. The convergence of these two advancements, the cost of sequencing plummeted. So while you still think it's expensive, it is so much cheaper than it was back in the 1990s when we were doing it very manually. So now what we have is this explosion of tests. So you can see on, I'm not sure what it is on my side, it's on the left, is the cost of the testing going down. Meanwhile, the number of tests commercially available is rising. So as of November of 2022, we have over 130,000 tests commercially available on the market. So that's a rough number. I swear it changes daily. In fact, the rough number is there's 2 new tests that come on the market each day. It's a lot. So that's a challenge, number one, for health plans, providers, people in general, to figure out where are we? What's useful? What's the value in these tests? How much should we pay for them? Are they of value? Do they change medical management? We should be using them, it feels like, all over town, right? But again, remember, our ability to read the book has really increased, but to interpret it and know what to do with it, we're still trying to catch up on that. Next slide, please. So the issue is that we have all of these tests. The truth of the matter is there's very limited tests that are used frequently. And so there's really sort of a few buckets that we're looking at. So the most commonly used buckets that really impact medical management, and we're going to talk about these in detail in a little bit, are in the prenatal tests. So these are the ones, remember we talked about, will my child have? Second are the hereditary cancer tests, which are, will I get? What's my risk of? And then that most rapidly growing test category are the oncology, diagnostic, and treatment. So those are the somatic tests, which are the, how do I treat this cancer? Are there targets for this cancer? So that's where we're going. Next slide, please. So a lot of the cancer, of course, happens in the Medicare population. So our spend in genetic tests has steadily increased with a peak in 2021. This cost of cancer care is a concern not only for Medicare, but for employers as well. So most of this cost is tied to rising pharmacy cost. However, of course, the genetic testing is a piece of that. So a lot of employers are starting to think about cancer-focused centers of excellence, which genetic testing could be a way to help mitigate some of this cost by really focusing on targeted treatments based on the genetic testing of tumors. This is a scary conversation to have because so many people are afraid of genetic testing because it's an unknown and it's been not very well understood. And again, it comes with a lot of the stigma of expense, lack of clinical utility. People don't really know what to use it for. And again, going back to the what is the value? There's been a lot of conversation about, well, it doesn't give me what I need to know, and it's very expensive. So that's part of why we like to have these conversations, is really trying to understand what genetic testing is and how can it help change these medical management issues. And that's part of the conversation about why I like to talk to health plans and providers and employers and patients so that we all can understand that this isn't a scary thing. It's just a matter of understanding where it fits. It's not the panacea. It's not going to tell us everything, but it's a part of healthcare. Next slide, please. Okay, so now we're going to talk a little bit about the types of genetic testing. Next slide, please. So the classic type of genetic testing that we think about is this diagnostic testing. And this is the part for people who have symptoms that their doctor is unsure what is causing them and they're unsure what to do. And this is really what we call the diagnostic odyssey. This is the journey of patients who have symptoms, and it takes patients and their families on average 5.5 years to get to a diagnosis. And 80% of these patients have a genetic disease. And so these are rare diseases where patients don't know what's causing it. And 5.5 years, they're bouncing around, going to specialists, tests, misdiagnoses with various specialists, traveling, all of those sorts of things. And you can imagine the emotional burden on patients and their families. So I'm going to try and do short personal stories here because I've been a genetic counselor for a long time. And so I'm going to tell you a little story. Actually, this one's personal. This one's a story about my little cousin. Henry is a twin, rough and tumble little boy. And Henry when he started walking, he would bump into things all the time and get these horrid gashes. He wasn't like doing anything crazy, just a normal little toddler, and he would require stitches. And by the time he was 3, he had been at the ER 5 times. Head wounds, knees, elbows, all of them. And then these wounds would reopen, right? So he would go back to the ER, he'd go to his pediatrician, and it was just this cycle. And my poor cousin was first-time mom, of course, thought she was a horrible mom, right? And the pediatrician kept telling her, you got to be more careful with him. Kept going to the ER, all of these things. And so you can imagine the emotional turmoil that she was under. Her poor baby is going back and forth to the ER, getting stitches, opening the stitches. And then finally, by the time he was 4, he ended up in the ER with a very large head wound. And this time they called child services. Luckily, they also called genetics. So it turned out that he has a condition called Ehlers-Danlos syndrome. And this is a condition that is a condition of connective tissue disorder where the skin is very fragile. And he also has joint hypermobility. So you have to suture those wounds with 2 layers of stitches and leave them in longer. So my poor cousin, I also yelled at her for not calling me sooner, but she had to go through all of those things because the doctors didn't know. They thought, he was just a regular toddler who just kept getting gashes and open wounds for no reason, even though his injuries were much more excessive than what one would expect from the type of activities that he was doing. So this is a very good example of where genetic testing could have helped much earlier in the diagnosis. And there's multiple examples of that, especially in the pediatric worlds. One thing that I'm really excited about at Quest is that we have partnered with several health plans and employer groups to offer genetic testing to babies in the NICU who have multiple anomalies. And this is done through the baby's caseworker. So when a baby is in the NICU with multiple anomalies, they actually offer genetic testing while the baby is in the NICU to help shorten that diagnostic odyssey and do the genetic testing before they're actually released from the NICU, so they don't have this loop of referrals to specialists. And we get that genetic testing done much earlier in their life, essentially. Next slide, please. And now the next type of testing we're going to talk about is pharmacogenomic testing. And this type of testing, it's really interesting because in the early 2000s, we thought that this was the answer. This is the type of testing that is looking at genes that are responsible for how your body processes medications. And we thought that the changes in these genes were going to help us really personalize medicines. We were going to be able to determine who was going to be able to have serious side effects from certain medications and who was not going to respond. And so we were going to be able to really focus our medication. it really hasn't turned out the way that we thought it would. Although there is a small population, especially in psychiatric medications. As you may know, about half of patients with depression respond to their first medication. And with each failed medication, their treatment intolerance increases. So they have to go through several medications in order to get relief from their depression. So pharmacogenomic testing is not available for all of the medications, but because there are certainly some that respond, some genes that are helpful in pharmacogenome or in those psychiatric medications, this is one area where there is some relief from doing the pharmacogenomic testing. The challenge, of course, is that normally you start your psychiatric medication and it takes a while for it to get into your bloodstream to see if it's going to work. So oftentimes you have to start the medication as well as do the pharmacogenomic testing at the same time. And so you won't know if your medication works and you won't know if your genes are conducive to that medication until you have to start them both at the same time, essentially. But there is some value there, and we're learning a lot more as we go along with the pharmacogenomic testing. Next slide, please. The next part, I'm just going to briefly talk about this because I think everybody likes to talk about it. There are a growing number of companies and employers who offer genetic testing as a benefit. And there's a lot of increased interest in consumer-driven testing, and there is a movement towards this. And there's some conversation about, is this wellness? Is it entertainment? And it really sort of depends. So I think we can all agree that if it's ancestry, it's very important that you all know I have a significant amount of Neanderthal DNA still in my body. So that's pretty much entertainment. The traits, cilantro taste, curly versus straight hair, definitely entertainment. But the challenge becomes, where is the health testing? Some of these do offer carrier testing for reproduction. Some of them do health risk testing. The challenge becomes, what responsibility do medical providers have to follow up on this testing? What responsibility do health plans have to pay for follow-up? It's a kind of an open debate on where does it fit into wellness testing, but it is out there. And so it's just important to know that some people are starting to do that consumer-driven testing. And so where do health plans, where do employers fall into that, and where does it fall in our health testing? Next slide, please. Okay, so now I'm going to switch gears a little bit. And we've talked a little bit about what is genetic testing, a couple of situations, and now I really want to focus on the genetic testing in cancer care. And again, mostly this is important because cancer care is roughly 12% of employer total medical costs. So anything we can do to reduce the incidence of cancer as well as the cost of cancer is going to impact healthcare. So first, we're going to talk about prevention and risk reduction. I keep bringing up the BRCA genes because everybody likes to talk about those. However, lots of types of cancer can run in families, including colon, uterine, pancreatic, all of them. The testing for BRCA1 and 2 has been available for many years. And when it came on the market in the early 2000s, it cost about $5,000. Now, remember, we've come from going to the library and getting the book to getting it on the internet. So the price has come down to about $1,800 for BRCA alone. But because we can now use our new technology, we can actually get a whole panel of genes for about $1,100. So we have at least 30 genes that we've identified associated with cancer that runs in families. And again, you can get that testing for a much lower price. again, though, you have to think about what are you going to use it for. For example, again, I have friends whose both mothers had breast cancer in their early 50s. And my friends who were young, 30s, they both were able to access this type of testing, and they both were able to find out that they had a risk for early onset cancer. And so then they had to choose what they were going to do with that and how were they going to decrease their risk of cancer. One of my friends chose to have a complete mastectomy and oophorectomy at 35. So she had complete removal of her breasts and her ovaries and decreased her risk of getting cancer by 90%. Now, you have to be able to have access to that care and have the ability to take time off from life to recover from that major surgery. My other friend had much younger children. She was not able to take that time off from work. And so she chose to have intensive screening. So she has screening every 6 months, but she's not doing anything to technically reduce her risk for cancer. Instead, she's choosing to do screening to detect cancer early. And this is important. So while you're able to access that risk testing, can you do anything with it? So the challenge here is that despite we've had these clinical guidelines in place to have access to the testing, what can you do with that testing? That's the important part that we have to talk about when we have access to genetic testing. Next slide, please. So the next part we want to talk about is how genetic materials in our the genetic material in our cells tells us what to do. So some genes are responsible for fixing mistakes, but if that gene has a mistake that makes it not work, then the genes that make mistakes can't be fixed. So if our ability to sequence our germline genes has improved, our ability to sequence our tumor genes has also improved. So that cost has rapidly decreased. So now we have an explosion of targeted treatments for cancer based on these genetic changes. So now we have all of these chemotherapeutic agents that are really high cost. So if you're going to use a chemotherapeutic agent that is very expensive, you want to make sure that you're using the one that is most likely to work. So next slide, please. So when we talk about biomarker testing or genetic testing in tumors, it's important to do it at the time of diagnosis. Approximately 25% of patients will benefit from tumor genetic testing because their tumor is predicted to either respond poorly to first or second line therapies, or it's predicted to respond better to a different drug that's in that first line therapies. So by doing these testing, we're actually reducing the waste of therapeutic agents. Also, the patient goes through suboptimal therapy. We're dealing with patients who may become too ill to get to the therapy that would work. So next slide, please. So part of what we're talking about is in the current model of cancer care, our care is very fragmented. So we have patients who may not get to the right therapy. They have to go through essentially the wrong therapy to get to the right therapy. So for example, if a patient doesn't have any genetic testing done, they may go through week 1, they get evaluated. Week 4, they have their biopsy performed. Week 6, they get their oncologist. Then they start their first line therapy. And then by week 8, they're on their first line therapy. And then the tumor results come back and they should be on a different one. So it's not until week 12 that they're actually on the correct therapy. So by doing genetic testing at that initial diagnosis, you actually can, number one, help the patient get on therapy earlier, and number 2, not waste that time or the therapy that is not going to help the patient. So again, I'm going to give you an example. I used to work at the Huntsman Cancer Center here in Salt Lake, and we had an outreach clinic in Jackson Hole, Wyoming. So our patients would come down to Salt Lake for initial surgery, and then they would go back to Jackson to receive their chemotherapy. So we had a patient who was started on first line therapy without genetic testing. She went back to Jackson to recover. She had a poor reaction to her first line therapy. She had to come to Salt Lake. We did the tumor testing and found out that that was the wrong therapy for her. And because of that, she could no longer stay in Jackson at home to receive her care. And now she had to stay in Salt Lake and receive her care with the different therapies. So not only did she receive the incorrect therapy to begin with, now from a social perspective, she couldn't have her treatment at home where she had all of her social support as well. So that genetic testing not only would have helped with her medical health, but her social health would have been also supported by that genetic testing. So when we talk about the value of genetic testing, it's not just always about the medicine, it's also about the person's social health as well. So next slide. I tried to talk fast because I know I was running over, which I always do. So I think what's important here is that I really want to hammer home that genetics has come a long way, and it's coming and it's getting incorporated more and more into our routine healthcare. And that is important. And part of that is because the cost is coming down, our knowledge is increasing. And as it becomes more commonplace, I am hopeful that some of these barriers will come down, and it needs to be accessible not only in these, ivory tower, high risk cancer clinics, but it needs to be accessible to all so that so everybody can have access to the best care. And sometimes that involves genetic testing as well. We have 7 minutes, guys. How'd I do?
Awesome.
I get passionate.
Excellent, Becki. Thank you. So like top of mind for me and folks in the audience, if you have questions, please enter them in the Q&A. But like I said, top of mind is what can our purchaser members do to make sure that there's not barriers to access, that patients are receiving the genetic testing when appropriate in a timely manner.
I think some of the most exciting things for purchasers that are coming up are things like the Cancer Center of Excellence models, where employers are able to give their employees access to those coordinated programs, where you're incorporating not only, again, the helping members go through this journey of cancer. It's a journey, and genetics is one piece of it, but most people don't understand it's a small piece, but it can have a big impact to the rest of their journey. Same thing with that NICU program that we have. That's an employer program, actually, that they offer to their employees. It's a small little piece. It's not going to affect a lot of their employees. But again, to that one patient, to that one mom, it's a huge impact. And it doesn't cost the employer that much because there's not a huge population. But again, to that one person, it's a big help. It's huge.
Thank you. So we have a question. So a little background first. So while the Federal Genetic Information Non-Discrimination Act prohibits insurers from asking for use of your genetic information to make decisions about whether to sell insurance or how much to charge, it does not apply to long-term care policies like life insurance or disability insurance. So this information can be used to decide whether to offer coverage or not. I understand that legislation has been proposed in several states, but as of now, Florida is the only state that has enacted a genetic privacy law. Can you talk a little bit about where we are with this in Washington State?
So I think, so now you're going to get my like personal opinion about this. I think the fear of genetic discrimination is greater than the reality of genetic discrimination, because of, again, what is the use of the genetic testing, right? So when we're talking about genetic testing in things like risk testing, will I get, is very different than do I have, and things like when we talk about somatic testing and, am I treating a certain condition? So when you're talking, the only sort of potential genetic discrimination could be along the lines of the risk testing. Will I get a certain condition? All of that. The truth of the matter is that insurance underwriters have had a really hard time incorporating genetic testing into their underwriting abilities. They can incorporate family history a whole lot better into their underwriting abilities than they can genetic testing, or if you're symptomatic.
Mhm.
So I know that people are afraid of genetic discrimination. I don't think the reality is that it is as big a deal as the fear of it.
Thank you, thank you.
Yeah.
What is the next stage that will dramatically decrease deaths from cancer? Is it better genetic testing or better treatments, and how is AI helping?
I think the answer to that is both, because the better genetic testing is targeting the better treatments. So our goal is to have more targeted treatments. The more targeted treatments will, most people don't die of cancer, they die of the treatments because the treatments are damaging the healthy cells. So the goal is to target the treatment. So the AI piece of that is, again, it's the more targeted treatment from the genetic testing.
Great question,
Yep.
Christopher Penn of HCA. So where do you see inappropriate, wasteful, or not cost-effective genetic testing that payers and purchasers should watch out for?
The risk testing. The risk testing is your biggest wasteful spending, because if you have a risk of a condition, is there something you can do about it? The biggest issue, especially in the cancer risk testing, there's also the Alzheimer's, the neurology, etc. If we can tell you if you have an increased risk of insert whatever, is there something you can do about it? And that's the important piece. And is it a risk that people are willing to do something about? I mean, we all know we should eat better, we should exercise, play mind games, all of those things to reduce our risk. If people don't do it, any kind of genetic testing is not going to help. It's not
So
going to
I
make
know
people healthier.
someone who was diagnosed with cancer and then had genetic testing to see if they were at risk for others. My assumption is that's an appropriate use of risk testing.
That's more appropriate use of testing for number one, treatment, and number two, family testing to determine if their family is at risk.
Okay. And then one more, but we're really at the bottom of the hour, but one more question. What resources exist to determine efficacy of specific genetic testing?
I'm going to do a plug for genetic counselors and genetic specialists right there. I think that's the best thing that you can do, is to reach out to a genetic specialist, because it's not just about, is this gene good? Is this gene good for this patient in this particular situation? For sure. Because again, can the patient do anything with this information?
Mm-hmm. Mm-hmm. Yeah, and I think it's I appreciate that honest answer. I think it's tough when a plan or plan sponsor is making a decision about whether to cover, and they don't have a resource to go to other than contacting a genetic, right? Yeah, that's Well,
We
Becki,
joke
we're
all the
gonna put our
time.
number out there, and
1-800 Becki. 1-800 Becki.
All right, well, thank you, Becky. Really appreciate the presentation. I've already received some emails saying what a fabulous presenter you are, and
Thank you.
appreciate you bringing this knowledge to folks at Washington Health Alliance. So, thanks.
Thanks, everyone.